And we are live. So, namaste, dear viewers. A very warm welcome to you from the GE Healthcare Education team as well as the JB Pharma team. Thank you for being here on time, on the dot. And we welcome you to this webinar session titled Virtual Echo Workshop with Dr. Sunil Bora. My name is Dr. Vikas Krishna. I am from the GE Healthcare Education team. And before we move ahead, a few quick opening remarks for you to benefit the most from this session. So to one side of this video frame, you will find a text box. Please use that to ask your questions at any time during this session. And we will take up all Q&A towards the end of the session. But the box is open. Please feel free to use it. Also, while this webcast will work on any device, what we strongly recommend is for you to use the largest screen that you have so that you really benefit from all the visuals which are going to be part of this presentation. And we will also have a feedback screen at the very end that will pop up once this session gets over. So please do fill that in for us and it helps us improve. And with that, I would like to welcome the medical team at JB Pharma. We have with us the Senior Manager of Medical Affairs from JB Pharma, Dr. Komal Mangaonkar. Dr. Komal Mangaonkar. Dr. Komal, please do the honors for us. Thank you so much, and it's over to you.
Yeah, thanks, Vikas. So, good evening to all. I am Dr. Komal on behalf of JB Pharma. Welcome you all for the today's insightful session on echo workshop, where we will get various insights on the echocardiography fundamentals. It's a privilege and honor to introduce our today's esteemed speaker, Dr. Sunil Bohra sir. Dr. Sunil Bohra sir is a senior consultant cardiologist from Fortis Multispeciality Hospital, Bangalore. Sir has a vast experience of over 22 years in echocardiography, highly proficient both as practitioner as well as educator, has been instrumental in setting up echo units with the prestigious centers such as Bhagwan Mahavir Jain Center, Bangalore. Well respected in the conference circuit, has contributed as a speaker as well as organizer for numerous conferences, and is several prestigious institutes, also holds IAE fellowship and serves in key leadership positions with IAE. So welcome Dr. Sunil Bohra sir, and now I request Dr. Bohra sir to please start the session. Sir, please.
Thank you, Dr. Komal and Dr. Vikas and Team G and Team JV Pharma for getting us all together. So I'll just share my screen. So good evening, everyone. Today we have all come together to know something about echocardiography, how it is useful in our day-to-day clinical practice, how we can diagnose patients with common heart condition, how we can follow up these patients to improve their quality of life and to optimize the medications, how it is useful. I hope this presentation on echocardiography inside some interest in learning echo and then doing echo by yourself. So the key learning modules of this presentation is to know some echocardiography fundamentals, how to do an echo, what are the views, what are the structures, what we need to see, and then obviously all the various aspects of the cardiac function. We'll go on to look at some echo clinical correlation, and finally, we can look at how to interpret reports. So before we start echo, we should know our machine. So this is the most important thing. So once you've decided to buy a machine, or if already you're owning or you have access to machine, there are various machines available. There could be standalone machines which are basic, which are advanced, which do a lot of functionalities, and there could be portable machines or handheld machines. So each one has their own advantages, disadvantages, their pros, cons, and then the various aspects on the cost. So before we actually start using echo machine, it is better to get well versed with the knobs and the buttons, so that you know how to utilize all the functionality of the machine. So various machines, various platforms are there wherein the echo machines are available. So basically, the basic functions will be the same in almost all the machines. Only thing is the layout of the buttons will be different. So once you buy a machine, or if you are moving from one vendor to another vendor, so basically the layout of the buttons will be changed, but the basic functionality will be the same. So you should always know which buttons are for what. I don't want to go into the details because this is an online platform. It's very difficult to tell. So probably when we do workshops or when we meet face to face, we can go into more details. So a lot of buttons are there. You can know each one of them, and you should know how to utilize all these functionalities of your echo machine. So the machine settings are very, very important. Most of the ultrasound systems are equipped with a selection of transducers with a wide range of capabilities and limitations. And most of the probes are capable of performing all the modalities, be it NM mode, be it 2D echo or a Doppler imaging. And most of the machines will have a wide range of transducers. So basically, it depends on the type of patient, whether it's a pediatric patient, whether it's a young adult or older adult who is obese, who is thin. So depending on the body habitus, also the probe frequency will change. So there are a lot of probes available, ranging from to 1.5 megahertz to almost 7.5 to 10 to 12 megahertz. And obviously, the transducer size and the footprint also is important based on the patient's body habitus. So typically, an echocardiogram is performed with the subject in the left lateral decubitus position, and 3 sinus beats have to be at least recorded if the patient is sinus rhythm, and 5 beats if the patient is in atrial fibrillation. And the most important is to optimize the echo images so that you can look at the endocardial borders and the valves per se very neatly. So how do we start? We start with the transducer orientation. So you can see here there is a button, some prominent mark which is there on the transducer, which should correlate with your marker on the image. So that means you're in orientation with the image. So whatever is, so you should just imagine that there is a ultrasound beam which is passing through from this thing, something like a plane which is cutting through the chest wall and the heart, and then you get this slice of this image on your monitor. So the probe marker has to be oriented based on your views, what you're going to look at. So once we start acquiring the images, we should know how is the optimal image, which is very, very important for a good echocardiographic examination. So the gain settings are very, very important. You should not undergain like this, which is seen on the left side of your screen, or overgain as you're seeing in the right side of your screen. So undergain means you're not able to see the endocardial border very clearly. The valves or the moving structures are not very clearly seen. Only those which are highly calcified like this, and the pericardium is very well visualized, but then the other structures you are missing out. On the other hand, when you keep the gain very high, you can see a lot of grains in the on the screen, and then where there is blood pool, there is also grains there, and then the valves can appear thicker. The calcification can be appearing more prominent. So you should know how to optimize your gain. So this is the optimal, one of the optimal gain images, wherein you can see that you're seeing the endocardial border very clearly. You're seeing the valves very clearly. You're not seeing too much of grain inside the cavities where there is blood pool. So this is a sort of optimally adjusted gain image, which is very good to read and interpret the findings. So once you've optimized the gain, you should know how the depth also, which is very, very important. So you should not keep too much of depth or too low depth or too high depth, which will again alter your the screen image rate, all those things. And the images should always be ECG gated, which is very, very useful in identifying the systole, the diastole, and then various measurements, what we can do, the timed measurements, the durations, etc. We can very clearly record or interpret if there is ECG tracing. And in some patients where there is no adequate visualization of the cardiac chambers, we can use an intravenous contrast agent, which helps us to opacify the LV or the RV cavity, and then we can visualize the borders very neatly. To start with, the patient position is again important. So we are finished with the mission setting. So then we always have to look at the patient comfort, the echocardiographer comfort. Usually we perform with the echocardiographer sitting either on the left side or right side of the patient, which is usually a personal comfort. Either you want to do with the left hand or the right hand, depending on your preferences. So the goal here is to achieve high quality images without creating anxiety to the patient and also to the performer. And either supine or left lateral position, depending on what indication is there, we can record the images. In for subpostural views, we usually make the patient lie down supine with the legs flexed. And in the suprasternal views, we have to hyperextend the neck as shown here in this image. So the various transducer placements, there are opportunities where we can look at the heart. The most common starting point is the left parasternal location. Here in the second to the fourth intercostal space, we can keep our probe and then start looking at the heart. So we can utilize the cardiac apex or the apical windows. Then we can use the subcostal window and the suprasternal window. Less commonly, we can use the right parasternal window. So once we have started to do an echocardiograph, there are various views which we look at. So this is the list of the views. We start with the parasternal long axis, then we look at the RV inflow view, we look at the short axis, then the apical 4-chamber, 2-chamber, 3-chamber, then we go on to the subcostal long axis, short axis, and move on to the suprasternal view. So this will be a comprehensive view wherein we can look at the heart in various positions. So to start with the parasternal long axis view, usually it is in the left third intercostal space where we start with this, with the probe, with the transducer, the marker position being at the 10 o'clock position or to the right shoulder of the patient. So once you have this proper alignment, then you will get a clear view like this, which is shown here. So here we can move 1 or 2 spaces up or down, or then slide the probe medially or laterally so that we can adjust and try to get this type of image. So here, once we have got this image, what all we see is these things, that is the RVOT, the LVOT, the LV cavity per se, the septum, the inferior wall of the LV, the LA, the mitral valve, the aortic valve, and part of the aorta is what we can see in this view. So once we have acquired a proper image, how to read it? So we have to scan it from the chest wall to the posterior wall like anterior to posterior. We need to scan and see whether there is any problem in the pericardial space, whether there is any pericardial effusion or any pericardial fat. We need to see. Then we need to look at the RVOT. This is the RVOT wherein we have very clearly seen it is contracting well and it looks normal here. Then we look at the septum. We look at the posterior wall, then we can look at the aortic valve, whether it's opening well, what about its thickness, whether it's thickened or whether it's calcified, whether it's opening well or restricted, all those things we can know. Similarly, we can look at the mitral valve, the anterior mitral leaflet, the posterior mitral leaflet, the chordae tendineae, which is getting attached to the papillary muscle. And we can define what is the pathology here by looking at it. And we move on to the left atrium. We see whether there is any abnormal shadows here, whether there is any clot or any other findings which are there in this region. Simultaneously, we also see the ascending aorta, the aortic root, and also we can look at this coronary sinus, which you can see here, a small halo which you're seeing. And we can see the descending thoracic aorta behind the LA. So, and also looking along the posterior wall of the LV, we can look at the presence of pericardial thickening or whether there's any effusion, etc. So all these things are seen in this view. So once we have seen the 2D, what we need to do next? So we can take an M mode across the LV. There are two M modes which we take. M mode is nothing but the motion mode. The importance of this is it is a very high frame rate image, almost 4,000 image frames per second we can see. So here, highly mobile structures, we can see their movement very clearly. And we are putting a line across this aspect, that is the aortic valve and the LA, and we can do the measurement. So here the important is the M mode, which is very useful to take precise measurements, which sometimes may be difficult in tachycardia patient, where we can't do it very clearly with a 2D based M mode. So this is very good for calculating the measurement. So again, we can take an M mode across the LV. The correct way is we need to keep the line perpendicular to the LV long axis and then cut it across the tip of the mitral valve. So here it is cutting across this anterior to posterior. You can see the subcostal, substernal region, then the RV free wall, the RV free wall, the RV cavity. Then we can take the measurements of the septum in diastole. Then we can take the LV internal dimension in diastole, and then the posterior wall in diastole. Similarly, we can take in systole, and then we can do the calculation, and we can get the EF, and then we can get all these things. So again, this is not recommended for calculating EF, especially wherein we need to use a biplane Simpson method, which I will be telling in the later slides. So once we have done the M mode, we next need to put a color Doppler and see for the color flow across the mitral valve and across the aortic valve. See for any turbulent flow, whether there is any forward turbulent flow in case of aortic stenosis, or a reverse turbulent flow in LVOT, which would be indicating of aortic regurgitation. Similarly, mitral valve, we can see if there is any flow turbulence across the mitral valve, indicating either mitral stenosis or mitral regurgitation. Again, we can see if there is any flow across the septum from LV to RV, which will indicate the presence of ventricular septal defect. So these are all things which we can see in color Doppler. So in this, it is almost normal. There is a laminar flow which is seen across the mitral valve and also across the aortic valve. So once we have looked at the parasternal long axis, what we need to do is we need to tilt the probe anteriorly so that we can open up and see the right ventricle and then the right atrium. So, and then also put a color Doppler to see if there is any tricuspid regurgitation, and then we can take the Doppler across this and then take the tricuspid, the RV systolic pressure we can calculate. So again, this is very, very important because the tricuspid valve we can see very clearly in this view, and then you can see if there is any pathology associated with it. So it gives a very clear view of the tricuspid valve also. So once we have done with the parasternal long axis, we can go on to the parasternal short axis. We have to just rotate the probe by 90 degrees clockwise, and we can get these views. So from the parasternal long axis, once we rotate it, we can get the short axis views like this. So here it is shown. We just the marker position is facing to the 1 o'clock position or the left shoulder of the patient. So from this region, we have turned we have rotated our probe to get the short axis. So here we can take numerous short axis, but the most important will be across the aortic valve we need to see, and then we can go on to look at the mitral valve, the papillary muscle level, and also the LV apical level. So what we need to just tilt the probe. Once we have rotated the probe, you tilt it, and superiorly you will get to see the aortic valve. If you tilt it towards the LV apex, you can see the mitral valve in its short axis. So again, when properly viewed, it allows optimal recording of the mitral valve, leaflet excursion, and also we can look at the LA appendage in this view. So here you can see here, this is at the aortic valve. We can see the three cusps here, the non-coronary cusp, the right coronary cusp, and then the left coronary cusp very clearly visualized here, and it is opening well. And you can see the This is called as the cup and the saucer arrangement of a normal great artery relationship, wherein you can see the tricuspid valve, the pulmonary valve, the main pulmonary artery, and then the branches of the pulmonary artery. You can see the LA here. And then if you tilt the probe little inferiorly, you can see the LA appendage coming here. And also you can look at the origin of the left main coronary artery and then the right coronary artery in this position. So here you can see the left coronary artery and the right coronary artery we can visualize here. And then in this view, you can see to a certain extent, we can see the left coronary artery here. So this is also very useful sometimes, and especially important in children, in neonates, to look at L kappa. And then once we tilt the probe a little bit towards the apex, we can see the short axis at the mitral valve level. We can look at the antemitral leaflet, the posterior mitral leaflet, and also look at the various segments of the LV and see if there is any wall motion abnormality at this place, that is at the basal level of the LV. So once you tilt it a little more towards the apex, you can see the LV short axis at the papillary muscle level. You can see the two papillary muscle, posterior medial papillary muscle and then anterolateral papillary muscle. And you can see there's some heads on papillary muscle. And then also simultaneously, you need to look at if there is any regional wall motion abnormality associated with this this one. So I'll tell you about the wall motion abnormality later when in the course of the presentation. So coming to, so we have finished with the apical long axis, the parasternal long axis, the parasternal short axis, then we move on to the apical views. So this is very useful. Once we scan the probe and go to the LV apex, we can look at various views, and this is very, very useful for looking at the chamber orientation and then Doppler evaluation across the mitral valve, across the aortic valve and the tricuspid valve. So again, here it's very, very important. So when you're looking at the 2D aspect, so if your transducer is parallel to the flow, then you can take good Doppler measurements. For Doppler measurements, your transducer has to be in alignment with the flow. As against, if you want to look at 2D aspect, suppose now you're looking at 2D aspect. So if your probe is perpendicular to this, for example, when we are looking at the intra-atrial septum. So if we are looking at the intra-atrial septum, there could be echo dropout here. That is because there could be the ultrasound beams don't pass through this thin structure. So if you want to see this, your probe has to come to the subcostal region, and your ultrasound beam has to pass perpendicular to this area of interest. So for 2D, your beam should be more perpendicular to the area of interest, and for Doppler, it has to be more parallel with the alignment. So again, in this 4-chamber view, you can see all the 4 chambers, the left side of the heart, the LV, the LA, the RA, and the RV. You can see the mitral valve here, and then the tricuspid valve, interventricular septum, and the intra-atrial septum. And you can see the pulmonary veins draining into the LA. So this is how you look at the LV, the heart in the apical 4-chamber view. So once you have looked at, you should, especially in infants, you need to look at the orientation and how you identify the chamber. So this is very clearly we can make out the right ventricle is having very trabeculated endocardium. There are 3 papillary muscles in this, but in the LV there are 2 papillary muscles. The cordia are inserted into the septum in the RV and the infundibula. The moderator band, we can see very clearly the cavity is triangular in shape, and this in LV it is more of ellipsoid. And the mitral valve leaflets, you can see the tricuspid valve attachment, the septal attachment is more apically placed as compared to the antemitral leaflet. So once we have done with the 4-chamber 2D assessment, we can go to the 5-chamber, and then by 5-chamber we get it by the apical view. You just tilt it more anteriorly, you get to open the aorta, and this is the 5th chamber which we are seeing here. And we can assess the flow across it, and then take a Doppler assessment and see what is the flow velocity across the aortic valve. Similarly, in 4-chamber view, we can look at, assess the mitral valve, flow across the mitral valve by putting color across this, and then also the pulse wave Doppler. And also across the tricuspid valve, we can put a color and continuous wave Doppler to look at the tricuspid regurgitation. So once we have done that, we anti-clockwise rotate the probe anti-clockwise by 30 degrees, and then we can get the two-chamber view. Here we are cutting off, we are removing the RA and the RV from the view, and we are just looking at the LA and the LV and the mitral valve at the commissure level. And here, this is very important to look at the LA appendage here. Again, we can assess the wall motion abnormalities in this view. And then we again anti-clockwise rotate by another 60 degrees, and then we can see the three-chamber view. That is the LA, LV, and then the aorta as the third chamber. So here you can look at the aortic valve and then the mitral valve. We can assess, we can put color, we can put Doppler assessment, etc. here, and we can evaluate the flow across the mitral and the aortic valve. So once we have done the apical views, we can go down to the subcostal views, and this is very, very important to look at the interventricular septum and the intraatrial septums, because as I told you, the ultrasonic beam is perpendicular to the LA intraatrial septum, and then we can assess whether there is any presence of intraatrial septal defect. We can assess the flow across the intraatrial septum, and also this is a good view to look at the tricuspid regurgitation and to calculate the velocity. So how do we do? We can put the probe in this position and take it. And then we can rotate the probe anti-clockwise by 90 degrees and then look at the short axis, the subcostal short axis. Again, it's very, very important to do subcostal views in patients who are having emphysema, who are not able, wherein we don't get good parasternal views. We can get almost, we can sometimes complete the full study in the subcostal views. So again, the subcostal view is very, very important. Like in patients with pericardial effusion, where then we can look at the amount of fluid. We can it will also help in assessing the needle position for pericardiocentesis. And then once we have looked at the cardiac things, we can move on. We can rotate and then look at the IVC. Especially important to look at the IVC dimensions, the collapsibility, especially in ICU patients, wherein we can see whether they are having like low cardiac output or a high cardiac output state, and then accordingly we can utilize these information to resuscitate the patient. In moving on to the suprasternal views, again, very useful to look at the arch of the aorta and then the branches and to assess the flow across, especially to look at the coarctation of aorta and also to assess aortic regurgitation. These are very, very good views. And from the suprasternal view, again, we can tilt the probe and then we can look at the SVC flow and then assess the flow in the SVC. So having said all these things, so these are the fundamentals of echo. So once we have known how to record the images, which are the views, then you're coming on to the clinical applications. So there are numerous clinical applications where echo can be used. I've just put three basic examples because of the paucity of time. So we look at use of echo in coronary artery disease or acute coronary syndrome patients. We look at hypertension patients, what all we need to look at. And then obviously the noise level on heart failure is very high. So we look at how echocardiogram is useful in diagnosing and monitoring patients with heart failure. So the role of echocardiography in ACS management, it is a standard tool in the management of acute myocardial infarction patients. So here echocardiography is useful in establishing the diagnosis, to localize the arterial involvement, and to look at the extent of the myocardial infarction. It is also useful in diagnosing the mechanical complications of the infarction and also in providing prognostic information that is very important for risk stratification. So before we venture into the echocardiography of coronary artery disease, we should know the coronary anatomy. I'm sure everyone knows this. But just for recapitulating, the left main coronary artery, the left circumflex, and then the left anterior descending artery, and then we have the RCA continuing as the posterior descending artery. So why it is important? Echo is important because it comes very well in advance before in the ischemic cascade, before any visible wall motion abnormality occurs. There various other things which we can look at, like perfusion abnormality or the strain abnormality, even in fact before the ECG changes, or even in fact before the patient develops angina. So this is a very well documented thing wherein echo plays a very important role in diagnosing the ischemic cascade earlier before the symptoms or ECG changes appear. So for coronary artery disease, we should know the LV segmentation. So there are the 6 views which are there. So how do we define as? First, we go with the short axis view. This is at the mitral valve level. This is at the papillary muscle level, and then the apical level. So how do we label the segments? Basically, we need to identify the septum. The septum is the region between the LV and the RV. So where the RV comes and attaches the hinge points of the RV to the LV, that is defined as a septum. So we draw an imaginary line and cut the septum into 2 parts. This is anteroseptum and the infroseptum. Similarly, the opposite segments will be anterolateral and infrolateral, and then the anterior and the inferior. So these are the basal segments. These are the mid segments. So these are both the same. So we have 6 basal and 6 mid segments. And the apical region, we have only 4 septums, because both the septal things, anteroseptum, infroseptum, are combined and appear as septal, and then the lateral, anterolateral, infrolateral are labeled as only one segment, lateral. And in the apical 4-chamber view, you can see the infroseptum and the lateral wall here. And the 2-chamber view, we can see the inferior wall and the anterior wall, which is divided into 3 parts: so the basal, mid, and then the apical anterior. Similarly, the basal, mid, and the apical inferior. And we have an apical cap. In the long axis or the 3-chamber view, we can look at the basal infrolateral, the mid infrolateral, the mid anteroseptum, and the basal anteroseptum. So the apical, lateral, and anterior is the same as the 2-chamber view. So this is very important for us to remember and understand. Why? Because the coronary artery distribution is based on these segmentations. So the left anterior descending artery, as you can see here, mapped in this pale color. So it supplies the apical septum, the whole of the anterior wall, the apical inferior wall, the whole of the anteroseptum. And the RCA is supplies the basal septum, the basal and the mid inferior wall, and then the RV, the whole of the RV. Similarly, the circumflex supplies the lateral wall. So we need to remember this. So before you want to assess a patient with the chest pain or coronary artery disease, you should not jump to conclusion with 1 or 2 views. You should always look at as many views as possible, and then you need to put everything in one, and then only you need to explain or write about each segment involvement, so that you can know whether there is any specific coronary artery distribution or whether there is any non-specific coronary artery disease, wherein it could be because of some other causes, like it could be non-ischemic causes, it could be like stress cardiomyopathy. There are so many other things which we can diagnose by doing a systematic echo. So again, once we look at the wall motion abnormality, there is scoring system: normal, hypokinetic, akinetic, dyskinetic. I'll not go into the details of this, but there are specific things which we have to look at. So normal is the definition. It's very difficult to tell online, so we will cut off on this, and then you should just remember that all these parameters can appear in the echo report. So coming to a case discussion of coronary artery disease, we have a 39-year-old female who complained of chest pain since 3 hours, which was central, radiating to the left arm associated strain. So typical classical anginal pain. She's a diabetic for 12 years, hypertensive, vitals, blood pressure is on the lower side, 110/60. Systemic examination is unremarkable. So the ECG showed very obvious findings. I'm sure all of you will be able to read this. This is having acute anterior wall MI. So there's acute ST elevation in the anterior chest leads. Obviously, our lab parameters, CPK, the cardiac enzymes were very high. So once you've done this and you want to start doing echo, you should know what to look for. So obviously, out of these, we will look at the ECG showed anterior wall. So we look at concentrate whether there is any septum and anterior segmental hypokinesia, rather than looking at the posterior wall, because the ECG changes. So here is the echo of the patient. Here you can see there is the anterior septum is thin and severely hypokinetic. As you can see, thin means you have to compare with the normal segment. So here the posterior wall is contracting well, it is thickening well, whereas the anterior segment is not contracting, it is almost thinned out as compared to the posterior wall. And you have to utilize as many windows as much as possible and then define. You can see here the posterior wall is hyperkinetic actually, whereas the lateral, the anterior wall, the septum, everything is hyperkinetic. So to compare with the normal window, I have just put a normal patient here. You can see here how it will look. So this is a normal patient on the lower panel, and this is our patient in discussion in the upper panel. So obviously coronary angiogram was done, which showed 90% proximal LAD stenosis. So it is confirming that our echo findings are consistent with the coronary angiogram findings. So coming to the second case, we had a 56-year-old male with chest pain radiating to the epigastric and the back. So, and his BP was low, 100/60, cardiac enzymes were raised, and ECG showed inferior wall MI. So you can see here QS complexes in lead 3 and AVF. So he had inferior wall, and obviously when we are doing echo, we concentrate on that, and then we see whether the inferior wall is involved. So here you can see the posterior and the inferior wall is hypokinetic as compared to the anterior wall, which is normal. So, and coronary artery, the angiogram showed RCA 90% stenosis. So in this patient, it's very, very important to do a detailed echo evaluation, because this is involving the right coronary artery. So once the patient is having right coronary artery, it is obvious that the RV function or RV has to be evaluated. So we look at the RV function here. So how do we look at the RV function? We have to look at the free wall motion and then the tricuspid annular motion. We can do some M-mode evaluation that is called a TAPC. I'm sure you'll be looking at the reports wherein the TAPC is mentioned. TAPC is nothing but tricuspid plane annular systolic motion, which we are seeing the movement of the tricuspid plane annular systolic motion. So normally it is more than 17 millimeters. So if it is less than that, that means the RV function is impaired. Similarly, we can put a tissue Doppler and look at the systolic movement of the tricuspid annulus. And obviously, we will be doing echocardiographic evaluation, the EF, we will be looking at EF, but then here, a word of caution, we should not rely on the M-mode estimated EF here, because this will obviously look normal, because the basal segments, especially in our patient, the right coronary artery involvement patient, wherein we are looking at these parameters, that is the left, the interventricular septum and the posterior wall, which may not have been affected, and spuriously your M-mode estimated EF may be normal. So in that cases, it is recommended whenever there is a regional wall motion abnormality, or whenever the LV geometry is not ellipsoid or it has changed, you should always do a biplane EF estimation. So how do we do it? We acquire a 4-chamber view in diastole and in systole. At end diastole and end systole, we trace the endocardial border starting from the medial mitral annulus. We trace the endocardial border up to the apex and come back to the lateral annulus. And we, by Simpson-Mintz, the biplane disc method, so the LV is divided into a lot of discs. Each disc volume is calculated automatically, and it is summed, and it gives the volume here. So here you can see LV end diastolic volume in apical 4-chamber view, 151 ml. Similarly, we go to the end systole, and then we calculate the end systolic volume. It is 101, and that gives your EF in 4-chamber view. Similarly, we need to do in other view, that is the 2-chamber view, the end systole and end diastole and end systole, and then we can calculate the EF. So in this patient, you can see it is EF is 31 as compared to the M-mode EF, which was around more than 50. So that is the importance of doing Simpson's estimated LVEF. Again, to go one step ahead, if you have a good machine which is capable of doing a triplane EF, it is like a 3D echo, it is very good. Here, the advantages, we are including the 3-chamber view also, and then we are calculating. So how do we calculate? We trace the borders in all the 3 views, and then it gives an estimate of the 3D EF. So it is also superior to the biplane EF. So having said all these management of acute myocardial infarction, we should always look at the complications of acute myocardial infarction, which is very, very important to diagnose and to follow the patient. So there are so many complications which are there. I just quickly run through all these things in few minutes because of want of time. Pericardial effusion, very clearly we can make out that if it is a mild pericardial effusion, like for example, day 2, day 3 of the post-MI, we can have something called as a Dressler syndrome, wherein it's a small effusion and then the patient will have chest pain, so you can diagnose this. It could be moderate effusion with tamponade features or without tamponade features. So the echo is very, very useful to look at this complication. Again, another dreaded complication, very useful. Echo is indispensable here. We can look at the ventricular septal rupture, whether it is in the apical region or if it's in the posterior region, we can find out and evaluate. LV thrombus in the long-term follow-up or acute follow-up itself, if the patient is having severe LV dysfunction, there could be a thrombus which is sitting here, and then patient can end up with a stroke, etc. So this is very, very important. The echo has a very important role in diagnosing these patients. So whenever we suspect a patient having MI with stroke, then we should always actively look at thrombus. So here in this case, you can see you're not very sure whether there is any thrombus, but then there is associated wall motion abnormality. So the degree of suspicion of thrombus goes up very high. So if you're not sure what is happening, you can always do a contrast study wherein you can very clearly diagnose this filling defect in the LV apex, which is indicator of a thrombus. Again, if a patient is having stroke and then there is no obvious thrombus which is seen in 2D, you can do a contrast image wherein you can pick up thrombus, which is very useful in starting anticoagulation therapy. So there are complications of myocardial infarction. The most important is mitral regurgitation. Here it could be chronic. So we have to differentiate between chronic mitral regurgitation and acute mitral regurgitation. In chronic mitral regurgitation, where there will be LV remodeling, the LA and the LV size would have increased. And there are other parameters which is beyond the scope of this talk. So we have to look at this. Acute MR, very, very important. Here you can see this. There's a papillary muscle rupture, and then the patient is having acute MR. This is very tachycardic as compared to a patient with chronic MR. Here you can see the patient heart rate is very normal. It's around 90, 97. But in patient with acute complication, when the patient comes with florid pulmonary edema, you should echo plays a very handy role, and sending this patient for immediate surgery will save this patient. Again, the chronic complication, LV aneurysm, again, very, very important. I'll come to this during the heart failure aspect. It is very important to diagnose this and then follow up and then treatment, helps in treatment or optimization. So once we've done this, echo is also useful for screening of ISD in the form of dopamine stress echo. Not going to the details, I'll quickly run it. So what we do is we give a dopamine infusion. At rest, we look at the wall motion abnormality. We increase the dose to 10 mics, 20 mics, 30 mics, and see if the patient develops any wall motion abnormality. So we go through the sequence of images, the 4-chamber, 2-chamber images at the various dosage of dopamine and see if the patient develops any wall motion abnormality. And there are various other things like LV dilatation, etc., which we see. So having said that, the next clinical important evaluation is the role of echocardiography in clinical hypertension. So we all know that correct diagnosis of hypertension and the precise assessment of the cardiovascular risk are very essential to give proper treatment to patients with hypertension. And understanding the conventional and the newer echocardiographic parameters is very, very important in the diagnosis and assessment of further cardiovascular risk in all these hypertensive patients. So why to do an echocardiogram in hypertensive patients when the patient is diagnosed or when the patient is not under control? So it's very, very important because hypertension per se, as you all know, it's a very silent disease unless until it is an advanced stage and the patient is already having end organ damage. So here we need to look at, we can do an echocardiogram to know the cause and effect of hypertension, which it will help us to guide in therapy. It will help us to risk stratify the patient and also to monitor the response to treatment. So pathophysiology of cardiac response to hypertension, we all know patient can develop left ventricular hypertrophy, and then there could be LV adaptation to the LV function to this increased afterload, and then there is change in the LV morphology and then the LA morphology, which we need to follow. Again, measurement of LV mass is very, very important. Identification of the LV geometric pattern is important. The tissue characterization, especially when you want to differentiate between various conditions which can cause LVH. You have to look at the LV systolic and the diastolic function. We can look at the cardiac impact of hypertension treatment and in the clinical management of hypertension. So morphology, again, we need to look at the LV mass. You can see here, it is obviously it is hypertrophy. We need to do the measurements. We need to look at the thickness in diastole. How much is the septal thickness? How much is the posterior wall thickness? And then based on this, we can calculate the various conditions. And LV mass, if you want to go one step ahead, we can do a 3D estimated LV mass or even by the 2D estimated mass, wherein we have to use the formula to calculate the LV mass. Again, it's very, very important because the LV mass and the regional wall thickness, what we tell, is very, very important to diagnose what type of LVH is there, whether there is eccentric remodeling or whether there is any concentric remodeling or whether there is dilated or hypertrophic cardiomyopathy. So the relative wall thickness is very, very useful. You have to remember 0.32 to 0.42. If it is more than 0.42, then it means concentric remodeling. If there is less than 0.32, it is eccentric hypertrophy. I don't want to go into the details. So here again, once we have looked at the LV, we need to look at the LA also, because usually because of the overload, there is usually LA volume, LA dilatation, and then you need to calculate the LV volume, which is indexed to the body surface area, so that we can follow up this patient. So normal range is up to 34 ml per meter square, the LA volume. So how do you do is by saying the Simpson's principle, we need to trace the LA border in end systole. So here you have to be in end systole. In end systole, the LA is the largest. So we need to calculate the LA volume in 4-chamber view in end systole and 2-chamber view in end systole, and then we can get the value, which is indexed to the body surface area. So we need to index it to the body surface area. So we need to calculate the body surface area, and then this is all easy. In the machine, if you have entered the height and weight, it automatically calculates to index to the body surface area, and it will give you a value here. So LA enlargement is a very important and independent determinant of stroke, cardiovascular events, and death in patients with hypertension. Tissue characterization, it helps to provide information about myocardial remodeling and also to guide targeted therapy. And as we all know, the increments in LV mass that occur in the setting of hypertensive heart disease are always not due to hypertension per se. So we need to recognize the tissue characterization. So these could be include athletic hypertrophy, presence of valvular disease like aortic stenosis, which can cause hypertrophy, infiltrative disorders like amyloid, etc., non-compaction, and a hypertrophic cardiomyopathy. So we need to differentiate. So it is very easy to characterized by echo. So for example, here you can see this patient is having LVH, but there is LV non-compaction here as compared to a patient with hypertensive heart disease. So this is because of hypertension, wherein you can see the tissue is looking, as you do, you will understand. And this is a patient with hypertrophic cardiomyopathy, wherein you can see there's a lot of hypertrophy, there is endocardial bright shadows which you can see. As compared to a patient with CKD, you can see here this patient has pericardial effusion, and then there is this in CKD, the tissue, the myocardium will be very, very bright. And in patients with amyloidosis, you can look at this as compared to a patient with hypertensive heart disease. So tissue characterization, I'm just giving few examples, but this is very, very useful and helpful in diagnosing certain conditions. Again, the last point, in hypertensive patients, assessment of aorta is very, very important, because hypertension is an important contributor to aortic disease, and any echocardiograph which is performed should include assessment of aorta. So whenever you are referring a patient for echocardiogram, make sure that the echocardiographer looks at the aorta, and then you should ask specifically to look at the aortic dimensions. So again, very important in patients who are more than 70 years old, abdominal aortic aneurysm is very, very common. So these are usually missed because we usually don't look at these particular things. So whenever a patient with hypertension, especially elderly patient, is there, you need to look at the abdominal aorta and look at presence of aneurysm. Again, importance of looking at coarctation of aorta, especially if it's clinically indicated, wherein the BP is different in different arms. You should always specifically ask for this whenever you're sending a patient for echo. Otherwise, usually if it is done by technicians, if it is done by lay people or in a busy clinic, they usually miss it. So assessment of IATA again by echo is very, very easily done, but it needs persistent practice and protocols so that you don't miss it. So ascending aorta, you can see here is the arch of the aorta. Here you can see the descending thoracic aorta just behind the LA, and then you can see the abdominal aorta. So the total picture is seen by echocardiogram. Again, LV systolic function, as I told you, linear method should not be utilized. You should use biplane modified Simpson method. And we can also use the 3D AF assessment and the tissue Doppler also we can use, especially to evaluate the diastolic function. So to go a step forward, if you want, we can do a strain imaging. I think I'll skip this for Echonev. And the diastolic function is very, very important in hypertensive patients. We look at the mitral inflow here, the E wave and the A wave, and then we look at the tissue Doppler and then calculate the filling pressure by dividing the E velocity by the E prime velocity at the mitral annular level. So the specific sign of hypertensive heart disease, I'm sure all of us know this. So it is all of the above: LV hypertrophy, LV diastolic dysfunction, and LA enlargement. So these are the things which we need to look at in any patient who is being referred for hypertension evaluation. So the contribution of echocardiography, again, echocardiography is useful to select the type of medications you want, and then depending on the clinical subset, we can target the therapy. Coming to the last, this one, role of echocardiogram in heart failure. Again, we all know heart failure is a complex clinical syndrome with symptoms and signs that result from any structural or functional impairment of ventricular filling or the ejection of blood. So echocardiography represents the gold standard to assess the cardiac structure and function by identifying the abnormalities in the muscle, that is the myocardium, abnormalities in the heart valves, and abnormalities in the pericardium. And serial echocardiogram is very, very important to assess the changes in the EF, to look at the structural remodeling and the valvular function, which is very, very important. So I'm sure all of us know this, the ACC, AHS stages of heart failure. So even at risk of heart failure, when patient is at risk of heart failure, we need to look at echo and rule out is there any structural functional heart disease, and especially in those patients with cardiovascular disease, diabetes, obesity, etc., or who are exposed to cardiotoxic drugs, especially in cancer chemotherapy, we need to look at, and echo plays a very, very significant role. And in also those who are having pre-heart failure, like we need to look at the structural heart disease and also the evidence of increased LV filling pressures we need to look at. And if the patient is already having symptomatic heart failure, I think there's no thing beyond the EF, because we need to calculate the EF by Simpson. So again, classification of heart failure by LVEF is very, very clear-cut laid out in the guidelines, wherein they are the terminologies are there: heart failure with reduced ejection fraction when the EF is less than 40% by Simpson. Heart failure with improved ejection fraction, wherein the EF was less than 40%, but then on follow-up with treatment, if it is improved to more than 40%, it is with improved EF. And with the mildly reduced ejection fraction when the EF is between 41 to 49. And in patients with preserved EF, when the EF is more than 50, but there is evidence of increased LV filling pressure. So especially when we are looking at non-invasive hemodynamic measurement, we look at the LA volume and the LA, the mitral valve E by E prime, which will tell us about the LV filling pressure. Again, trajectories of heart failure based on EF, it's very, very important, because if you're doing serial assessment by echo, we look at patients who are having a heart failure with reduced ejection fraction, wherein they remain to be having EF less than 40%, or with treatment they improve, and we label them as heart failure with improved EF. Those patients who are having mid-range EF, they can go down to reduce ejection fraction, or they remain in mid-range, or they improve beyond that. And those patients with preserved ejection fraction, again, they can move to any one of them. So the role of echo is important, especially in monitoring these patients to look at the left ventricular dimension. We need to serially do the measurements, and it's important where you do the measurements. So if you're especially doing by M mode, it is useful only for LV internal dimension measurements in cases of heart failure, not for EF calculation. So we look at the LV internal dimension in diastole and look at how the patient is progressing, how the remodeling is appearing. And also by doing Simpson, we look at the volumes, what is happening to the volume status, and then we can also look at the wall thickness, whether there is any remodeling occurring. So left ventricular systolic dysfunction, echocardiography has many other roles beyond the recognition of systolic heart failure, since the dilatation of the LV results in alteration of the intracardiac geometry, they alter the hemodynamics, which again leads to increased morbidity and mortality. So when we look at the left ventricular dysfunction, so basically we are looking at these four types of heart. That is, there is a weak heart. That is, there is predominantly left ventricular systolic dysfunction, or whether there is big heart, especially when there is ventricular remodeling. As example, I showed you a case of LV aneurysm. So if the patient has already developed LV aneurysm, then there is a remodeling, and then the heart it increases in size, and then the patient has problem. As against a patient who is having noisy heart, that is presence of mitral regurgitation, which again becomes chronic, and then there is LV remodeling, there is LA dilatation, there is LV dilatation, and the patient has heart failure. As against a patient with stiff heart, that is basically the heart failure with preserved ejection fraction, wherein there is predominantly left ventricular diastolic dysfunction. So example of this patient, these patients, like for example, there is all systolic dysfunction, wherein you can see that there is global hypokinesia here, and as against regional hypokinesia, and then this is going into LV remodeling, wherein there is LV aneurysm formation, and this patient is having mitral regurgitation as a consequence of the heart failure. So a few points about the left ventricular diastolic dysfunction. It refers to the presence of abnormalities in the filling of the ventricle. Here, what we look at is we look at the mitral inflow. We look at the pattern of the early inflow velocity and the late atrial kick velocity, and grade according to this: grade 1, grade 2, grade 3, grade 4. Very useful is the tissue Doppler estimation, wherein it helps us to mainly differentiate between the normal and the pseudo-normal pattern. So here you can see this is a grade 1. This is looking like normal. This is grade 3, wherein there's a tall E and a small a, and then there is grade 4, wherein there is tall E and a very small a without any respiratory variation. Here in grade 3, there is some respiratory variation. Obviously, we need to look at the tissue Doppler in all these things. If the tissue Doppler, the E prime is less than A prime, then it becomes easy for us to grade the category of the diastolic dysfunction. So again, very important is whenever we're looking or talking about the diastolic dysfunction, we need to talk about the LA volume, indexed LA volume. So we need to trace the endocardial border. We calculate, as I told you, in the hypertension aspect. Again, in heart failure patients, we should do serial assessment of the LA volume and help. This will help us to know what is happening to the patient with the treatment, whether they're improving or not improving. So to end with my presentation, we'll just discuss a small case on about heart failure, how it is useful, how echo is useful. So we had a 49-year-old female who came with breathlessness at rest and also had dyspnea while walking, difficulty in climbing stairs for almost 1 to 2 months. She had a past history of an NSTEMI, coronary angiogram, revealed triple vessel disease. She underwent PTCA to LAD in March 2021. 1 week prior, so she was hospitalized and was treated with diuretics, with oxygen, beta blockers, digoxin, spironolactone, and ACE inhibitor in the form of ramipril. So on clinical examination, she was having blood pressure on the lower side as expected, but she was tachycardic, and she was slightly on the obese side, and she had fluid overload signs. So on ECG, it showed a poor R wave from V1 to V3 and early repolarization in V2 to V3. Echo, obviously, we looked at various parameters. She had a dilated LV with the LV IDD of 5.8 centimeters. She had LV global hypokinesia, moderate LV systolic dysfunction with EF of 35%, moderate MR, TR, PSP of 60, and she also had slight IVC dilatation, and her NT-proBNP was raised. So her medication was changed post 36 hours of washout period of ramipril, sacubitril valsartan 50 mg twice daily was initiated. 3 days post initiation, our blood pressure was dropped. For almost 3 days, it remained less than 100 by 60, but sacubitril valsartan was continued for around 4 to 6 weeks. And after 4 to 6 weeks, when she came back, she was numerically stable. The symptoms improved in just 2 to 3 weeks. Her NOHA class improved from class 3 to class 2. Her NT-proBNP dropped, and sacubitril valsartan was up-titrated to optimum dose. So 1 year after the treatment, when we followed up, she mildly improved. Her symptoms was definitely better. Echo parameters also were better. There was no progressive LV dilatation. There was, in fact, a mild regression from 5.8 to 5.7. Her EF improved from 35 to 40 to 42%. Her MR reduced, and her RV pressure reduced, and a global hyperkinesia remained, but then it was better. So post sacubitril valsartan initiation, this HEPREP patient is showing significantly better results in real life, both by 2D echo, laboratory findings, as well as the quality of life. So again, this is one example to say that what is the importance of doing serial echocardiographic assessment, so that we can correlate whether the patient is improving, what is happening to the LV, whether the remodeling is happening, what is happening to the mitral regurgitation, what is happening to the LA volume, what is happening to the fluid status. So we can serially monitor. So the last slide, how to read the report. So I'm just given one example, echo report in a hypertensive patient. So basically what we need to look at is the parameters, the basic patient details, which you need to always cross-check whether you're reading the same patient's report. Look at the time when it was done, look at the parameters. This is very, very important. So if a good echocardiographer is there and a good lab is there, they should always mention their pulse rate, mention the blood pressure, which is very, very important during when the echo was done, because this has significant implications on the estimation of mitral regurgitation or any regurgitation and stenosis, valvular lesions, etc. We need to mention the body surface area. And then typical echo report will look like this, wherein the MOD measurements are given, the various measurements are given, so you should know how to read this. So AO is aortic dimension in the parasternal long axis view, parasternal view. In the LA dimension in parasternal view. Again, the LA dimension can vary in the parasternal view, in the four-chamber view. So if they have mentioned that they have done in four-chamber view, it will be mentioned here. And look at the interventricular septal dimension in diastole, in systole, the posterior wall dimensions, the left ventricular internal dimension in diastole and systole, the end diastolic volume, end systolic volume, fractional shortening, the LV mass. And again, you need to look at the Simpson-derived ADV and ESV, and the right heart measurements, the RV function measurements, the valvular assessment, what is the flow gradient across the valves. And you can go in more detail and see if there is any descriptive findings, which they have given here. They have given here the LA is dilated. I think I zoom on this. Yeah. So the left atrium is each of the chambers. So basically what you have to look at is all the four chambers we are looking at, and the left atrium, right atrium, left ventricle, right ventricle, whether there is any abnormality, what about their size, what about their descriptive findings we can look at. We can look at the wall motion abnormality, whether there is any descriptive findings which have been given here. We look at the four valves, if there is any mention on the valves, whether there is any abnormality. Look at the great arteries, the aorta, the pulmonary artery, the veins, the descriptive findings. We look at the intraarterial septum, interventricular septum. We look at the color flow, whether there is any mention about any regurgitation or any flow turbulence across any of the valves. We look at the Doppler study, see if there's any mention about the diastolic dysfunction, and also mention about the filling pressures. And some things about the pericardium, whether mention about the effusion, etc. And then also any mention about the cardiac thrombus or others. Finally, we go to the conclusion. Conclusion, usually we look at whether there is any specific things which are highlighted here. In this hypertensive patients, we're looking at the presence of LVH, the LA dilatation, whether there's any wall motion abnormality mentioned, what about the valves, what about the pulmonary hypertension, the diastolic function, and the systolic function. I think I'll end here, and we can take questions from the audience.
Yeah, thanks a lot, sir. Thanks for such an wonderful, insightful session on the echocardiography fundamentals. Now, I would like to take some questions from the audiences. Yeah, so here we start. So the first questions, which is better method to access the mitral valve area?
Mitral valve area, basically, we are looking at the planimetry. That is the best method. If there is no calcification, planimetry is the best method. The other methods, basically, we look at the pressure half time, and we can calculate the estimation based on the Doppler estimate of the valves.
Yeah, thanks, sir. The next question, how to approach about wall thickness in patients with hypertension and long-term diabetes?
Hypertension and long-term diabetes, basically diabetes will not have any problems. It's based on the hypertension itself, we need to calculate the risk stratification.
Thanks, sir. Assessment of IIS is best in which view, sir?
Subcostal view. Intra-atrial septum, I mentioned in my talk. So intra-atrial septum in the subcostal view is more perpendicular to the ultrasound beam. So it is more precisely we can evaluate the intra-atrial septum.
Yeah, thanks, sir. How to quantify RWT and LV mass in case of patients with hypertension and aortic stenosis?
Can you come back? What was that?
Yeah, sir. Yes, sir. How to quantify RWT and LV mass in case of patients with hypertension and aortic stenosis?
So it is the same phenomena. So we need to calculate the regional wall, the relative wall thickness. There's no specific criteria for that. So we have concentric remodeling or eccentric remodeling.
Yeah, sir. Next question: grades of mitral regurgitations. Can you please explain?
No, this is out of the scope of the talk, so it is very difficult. It almost requires more than 2 hours to take one class on mitral regurgitation itself. So this was just an overview of the echocardiogram. I think as and when we go and we look at more detailed evaluation of each and every pathology, I think we will be able to.
Yeah, how to calculate LA volumes?
I showed in my presentation. No? So we have to do by Simpson method, the 4-chamber view and 2-chamber view, and then we need to calculate the, we trace the LA endocardium, and we get the values.
How to distinguish calcifications when gain is increased to the optimized image?
So we need to, if you want to look at calcification, we need to undergain. So we need to reduce the gain and see if there is still bright echoes which are seen. Then it means there is definite calcification and significant calcification.
Yeah, the next question, is it likely that echocardiography in future can replace clinical examination, or it's a win-win, it's go hand in hand with the clinical examination?
It goes hand in hand, but then already it is taking a upper step, wherein the clinical examination is coming down day by day, and we are relying more on technology to diagnose diseases. But then for a true clinician, it will go hand in hand, and it will help in confirming the clinical diagnosis, or reverting, or going against, means cancelling the diagnosis.
Yeah, so that's it. These are some questions we got from the audiences. Now I request Dr. Vikas to give your views.
Thank you so much, Dr. Komal. So that was a really interactive session as far as the questions went. And before we wrap up, sir, our gratitude to you for giving us such a thorough discussion, such a thorough exposition. And I really hope that talks like this really stimulate our audience to pursue what is becoming an essential add-on to the clinical exam. And like you said, in some cases, it may even help us to diagnose things much earlier. So I really wish that this session was beneficial for our participants. And I would also like to take a minute to thank the team at JB Pharma for making this gathering possible, and for the interesting and very useful start to this learning journey. And one more request to our participants: when you stay back, this live feed will pop up a feedback form. It's a very quick one, just 3 questions, just 6 clicks, you should be done. So we really invite your feedback so that we can plan better and better programs in future. And one final thank you to the team behind the scenes, which is making all of this possible to so many of us simultaneously. So once again, my thanks to everyone. Sir, it was great to have you. Dr. Komal, it was wonderful to have you as well. And that is all from our side for this time.
Thank you.
Yes.
Thank you, Team G and Team JP Pharma. I hope the session was useful and it reached to the target audience. Thank you.
Thank you, sir. So on behalf of JB Pharma, I would like to thank Dr. Sunil Bohra, sir, for such an excellent, insightful sessions, which is very useful for all our audiences. Thank you, sir. Thanks a lot. We will look forward for more sessions like this. Thanks, Dr. Vikas. Thank you, sir.
Thank you.
Thank you so much. Thank you so much, sir. Thank you so much, Dr. Komal.